We're here at MedTech World Summit 22, and together with us today we have Prof. �W𝐞𝐝-𝐿, who has a very successful career in digital health, and I need to read the long list of accomplishments, but essentially Prof. Miller is an advisor for the Department of Healthcare and Social Care, an advisor for the NHS. He's also a part of the roster of experts for the WHO, amongst a lot of other things, but I think that's probably the most recent ones. So first of all, thanks for accepting our invitation to speak at the conference itself and also for this interview. And maybe before we delve into the health tech part of things, how do you enjoy Malta? I know it's not the first time that you've been here, is that right?
It's the second time. I came here for a holiday some years ago. It's a lovely island and has a great history, and there's great links between Britain and Malta that go back an awful long way. So I'm very pleased, and thank you for the invitation to come and speak here at the conference, and I'm very much looking forward to it and enjoying my time here.
Great. So maybe we can delve now into the healthcare side of things. So maybe my first question is, how have you seen healthcare change over the years, especially with the recent digitalization, let's say, of healthcare, which there's still a long way to go, but...
So I was fortunate enough to be involved in some early digital health implementation. So within the NHS in England, we had a large program back in 2004, which was called the National Programme for IT, which was about, because NHS is divided across several countries in Great Britain. So we have Scottish NHS, we have Welsh NHS, we have a Northern Ireland NHS, and an NHS in England. And I got a position there on NHS England, and it was a £13 billion project to bring in e-health records across England. And it was a much challenged programme, I think largely because it was one of the first of its kind in the world of any size. So that was a very interesting start, and we were pioneering at that time. And the biggest challenges were, we could see back in 2003, 2004, that our population was ageing. And that with that came the growth in demand for healthcare services. We also recognised that as that happened, the cost of healthcare to our government, because it's largely a government-funded operation, would increase. And that's true globally, everywhere.
Definitely.
And so we started to implement electronic health record systems at the primary healthcare level and at the acute or hospital level. And we also implemented diagnostic imaging, PACS-RIS, CT scanners and so forth, as well as computerization of our pharmacies and developing clinical ontologies to give us a fixed vocabulary for healthcare. So I was involved very early on the development of SNOMED CT, Systemised Nomenclature of Medicine, which subsequently came out of the NHS and went to the IHT-SDO. And although our programs struggled, because really I think one of the issues that we faced was the products that were available on the market were probably early and not necessarily fit for purpose. Although there was a history in Britain that went back to the 1980s of our primary healthcare app being computerised. I think we were one of the first in the world to do that.
Interesting.
Acute sector wasn't well computerised. And although some decisions were made to buy certain products, I was brought in because I had an area, London and Southern cluster, about 20 million people. And we weren't making the progress they wanted to. So they brought me in to try and see if we could get
moving on.
So the first job they gave me was to implement the primary healthcare solution, which they'd purchased a product called Vision in Practice. And I probably wasn't as elegant as I would have liked, but that was the beginning of it from my perspective. And I got up about 90 sites with GPs having that product. And then I was asked to move on. I got it to a kind of automated process for implementation, not totally implemented, but and that went up to 1,200 sites in London. I then got moved on to the acute solution, the hospital solution, and they'd bought a product that turned out not to be fit for purpose. And I was sort of hurriedly tried to find an alternative, and we settled in London and Southern on a product called Cerner, which was relatively new at that time, certainly in the UK.
Yeah.
And we implemented, I think, 74 acute sites, and which was probably the largest success on that program because it covered the whole of England.
Yeah.
But other products that had been purchased didn't turn out to deliver the thing that they wanted. So also the automation of labs, we looked at limb systems to try and automate that, and diagnostic imaging. So it's about trying to handle the fiscal sustainability of healthcare going forward, which challenges, I think, every country in the world.
Yeah.
And also we know that there's a shortage of clinicians and allied professionals, and that's unlikely to be rectified in the near future.
Yeah.
So we have to try and automate as many of the processes as we can. But it's not as simple as it first of all appears. I think healthcare, it's fair to say, is probably one of the most complex sectors of the economy. It's vocabulary, it's technology.
Yeah, everything. Yeah.
Right. And there's sometimes an arrogance that, oh, we've done finance, we can, why are these people struggling?
Yeah.
But when you look at something like systemized nomenclature of medicine, there's 450,000 concepts. I don't know of any other sector of the economy that has that kind of complexity.
Yeah.
And unfortunately, just having SNOMED CT is insufficient to deal with the problems that we face. So if I look, for example, at lab results in my country, even today, we don't have standard for naming conventions, reference ranges, units of measure, and the same with diagnostic imaging tests.
Yeah.
And although we've implemented some vocabularies for a dictionary of medicines and devices, what we find in England is we've not consistently implemented that across the whole of NHS England.
Yeah.
So there's a lot of work to do still on the vocabulary ontology side.
Yeah.
Why is that important? It's important because England, like many other countries who've invested in this technology worldwide, find that their data is siloed.
Yeah.
And what we want to have is semantic interoperability, so we can take data from any site and form a unified summary patient care record that's available to any clinician, allied professional in any location within our NHS. And after 20 years and 30 billion of expenditure, we're still unable to do that. So it's one of my crusades. Sorry if I'm going on.
No, I mean,
to address this problem of semantic interoperability, which is very fundamental, and we still haven't done it, although there's been some recent initiatives around the world that suggest finally we may be beginning to address that problem.
Because I know as well that in terms of interoperability, which is obviously one of the most, I think, important things that's really to get right just now. So speaking of NHS England, when you, for example, compare that to NHS Scotland within the diagnostic imaging, where all hospitals access the same PACS system, whereas that's not available yet in England. So someone who, for example, is treated in Manchester, someone in Liverpool can't see their images if they're transferred. So do you feel like interoperability is, we're still kind of away from gaining, so to use the word, universal interoperability there?
Yes, we are, and that's a global problem in my experience. I mean, Scotland does very well, I have to say, but I moved on from the NHS after 4 years. I got it about as far as I could on that program, okay? And I went off to Qatar to help them start their e-health program. I spent 2.5 years there, got them started on digitisation. I then went to Australia, where it's largely state-based, and helped them rewrite their e-health strategy. And that was about using such technologies, also the development of polyclinics, so that we moved towards a more integrated care system. And I think that's one of the big changes. that we're looking for e-health systems to help us with.
Okay.
So that we move away from a fortress structure of primary health care, acute care, mental health care and social care into a integrated care system where it's patient-centric. Now that's a wonderful objective and it offers many potential benefits. But unfortunately today our information systems are not sufficiently capable of being able to share the information through all those domains, and that's critical to that. So one of the areas that I think we need to see is the development of our clinical ontologies and not be left to individual organisations to choose whether they use them or not. Yeah. And we've seen that recently in the EU, for example. The EU is now going to mandate that there are fixed vocabularies, ontologies that have to be used, and that's the European Commission across the whole of the EU nations. Yeah. We've seen it with Scandinavia. There's the Nordic countries, 5 Nordic countries, have now started a major programme to cross-border, cross countries. So Finland, Sweden, Norway, Iceland, for example, can share that data. Now
that's very interesting.
They've given themselves a 10-year time to do that. But it means that we're going to have suitable ontologies, and just using ICD-11 or SNOMED CT is insufficient to cover the whole vocabulary, as you would be aware. But getting people to agree that
that's the challenge, isn't it?
Is a major challenge. and the result is that healthcare costs, we haven't really seen the benefits that e-health can deliver because of those challenges that we still face. We've seen in the United States recently, Larry Ellison, the head of Oracle, purchased Cerner for $28.8 billion. And he's saying he's going to build a system for the United States where they can share data between all facilities, which is something they cannot do.
At the moment,
And I wish him well, and I hope he does well, but it's a big challenge, and there are reasons for that. There's a sense that we can use maybe natural language processing to take data that's been different words for the same thing. But the problem with that is you get an error rate, and when you get an error rate with natural language processing, that results in unnecessary deaths or serious injury. So we have to be very careful. It's not just a simple AI problem. Yeah. I think it's much easier. And I think this was recognised in the airline industry in the 1930s when they decided that ambiguity led to increased risk, so they went for one language. Yep. Now, although it's not as structured as we want in healthcare, I think it gave an example of where healthcare needs to go. Yep. And one of the things I've been working on is trying to bring organisations like the 𝐼HT-SDO, the WHO, NHS, the British Standards Institution, which operates globally, to see if we can get the various stakeholders, both in terms of large corporations and providers, to see if we can get an agreement about what this complete vocabulary would look like, and can we get people to agree and sign up to it. Yeah. And there's some evidence that would be the case. I mean, in the United States of America, we see organisations like Amazon, for example, and I've already mentioned Oracle, Cerner. And in China, we've seen such organisations as Huawei and Newsoft also going down that same direction. And we see organisations, corporations like Samsung, for example, are moving in that direction. And I think healthcare is moving, and COVID probably helped that to start, moving more in a direction of telemedicine playing a bigger role. However, there are some issues with that. It looks like a wonderful solution. Unfortunately, in the UK, we're having economic problems, as you're probably aware. Yep. So it's estimated now that we have 8 million people in Britain that either can't use the internet, don't have access to the internet, or don't have access to a device. And therefore, how can those people access telehealth if they sit outside? That's just one area of challenge.
Does it create kind of health inequality?
Yes, it does. Way, so. We've got the health inequality from an economic point of view. Yeah. We've got health inequality from a
literacy, perhaps, point of view.
Literacy, but also from ethnicity point of view. And one of the battles that I'm trying to wage is that we have a more unified approach at a time when resources are increasingly scarce.
Yeah, definitely.
But I think if we want to keep a successful system, and the reason for that, I think, if we look at the research from the Commonwealth Fund in the United States of America, their triennial report, Mirror, Mirror on the Wall, 2014, 2017, 2021. What we see is they compare 11 leading industrial nations' healthcare systems. So the UK, Canada, United States, Sweden, Germany, Australia, New Zealand, Canada, as examples. And what we saw in 2014 was of those 11 nations that were compared, the UK was one of the cheapest at around $3,450 per capita. The United States was around $8,500, which was more than twice as expensive per capita.
Wow, that's...
And the clinical outcomes were the worst in the United States of America of any of the 11 nations. And also with the American system, actually, although people think it's a private healthcare system, 55% of the funding is actually federal funds. It's actually taxpayers' money.
Yeah.
And so one of the things that I've struggled with, and no disrespect to the Americans, I want to be very clear about that, is why when we want to modernise the NHS do we look to America to supply the solutions to that?
Especially when you have all that money which doesn't really buy you necessarily better healthcare, does it?
Look, 40 million of their citizens don't have access to healthcare, and 500,000 people go bankrupt every year because they can't pay their healthcare bills. And that's, that's the difference. But I think what I was quite impressed with was the dynamic of China. I was asked to speak over there about 3 years ago.
In fact, it was one of the questions actually I was going to ask you.
Sorry.
No. It's because obviously you've worked in loads of countries, like you mentioned earlier, and maybe I was to generalize it a bit. How do you see the experience of the classical Western countries versus the emerging countries and Asia? Is there a significant difference in the way that they conduct healthcare? Do you think that maybe your emerging markets are more open to act quickly, change quickly as well?
Yes, I think they are. I think sometimes there's an attitude in the West that we are technically superior, and
exactly.
the initiatives come from the West. And because we were early starters, you get legacy issues in the West that Asia has the opportunity, though they don't always do it, to avoid. And when I was asked to speak in China, I was sort of unsure about what I was going to see. I was pleasantly surprised, I have to say. They took me all over China. And I saw some of their indigenous software, a company called NeuSoft, NEUSOFT. I went to a hospital, 2,500 bed, 27th floor, very modern.
Quite big as well.
Yeah, quite big. And their software they were using was HIMSS Level 7 approved. And there were no HIMSS Level 7 hospitals in Britain at that time. So here I was in a country I was not aware of the progress they were making. And it was really significant. And I also was fortunate enough to go and visit the �WHAI complex in Shenzhen in the south. And it's a major, I've never seen anything like it in the world, not even in Silicon Valley. It was remarkable in size and scope. And the work going on there was very impressive. And I got slightly involved, I'll give you an example, with the Philippines. Now, China's helping the Philippines to build a universal healthcare system for the first time in their history. And what the Chinese can bring is 5G, for example. So �WHAI are going to roll out 5G right across the Philippines. And with low-cost devices, it means that 60 million of their 130 million people will, for the first time in history, have access to healthcare.
That's a lot.
And so,
a lot of people.
And also I would say that about the Middle East too. I only spent a year in Saudi, but I found that Saudi was making huge strides in terms of the development of digital health within Saudi Arabia, and they've gone on now, they're building a new city called NEOM, and they're looking to build the world's exemplar for digital
That's
health.
interesting.
And so yes, I mean, I think maybe the West needs to wake up a little and stop thinking it's
definitely.
in a unique position.
Yeah.
And that's encouraging, because we're seeing developing countries, and the universality of healthcare for those people is a wonderful gift. And the thing that I suppose I personally think, not speaking on behalf of the WHO, is that geopolitically that can play a huge role. So if in Europe, for example, we would assist some of those developing nations to have comprehensive and affordable healthcare, then I think we win friends and people don't forget. And I think sometimes but that's, I think, an opportunity that we miss.
Yeah, definitely.
And of course, there's Africa as well, and so forth. And I think we should approach that in a more open and transparent and caring way, because I think there's good business for our companies, but also there's long-term relationships
between
which are
both
important.
countries, definitely.
Sorry if I'm going on.
No, it's fine. I mean, it's quite enlightening, and I think the points that you're obviously mentioning are very valid. Maybe one final question, kind of to close off this wonderful talk that we've been having. What piece of advice would you give future health tech leaders? Obviously, you've been extremely successful in your career, so I'm sure that our viewers at home would kind of cherish a few words of wisdom for yourself.
Well, I'm glad you think I can give those words of wisdom. But one of the messages, because when I go to a different country, a new country, and they want to have digital health, which is laudable and the right way to go, I tell them, look, this isn't just about the technology. The technology is an enabler. But my belief is that it should be clinically led. All right? That these projects are not IT projects. They are clinical improvement projects with IT as an enabler. And when you tell them that, sometimes they look at you a little strange, and they're thinking, well, if we buy 𝐿𝐸 software, all our problems will be solved.
Yeah.
And actually, I try to encourage them to understand that's not the answer. So very simple things that don't sound highly technical, like begin by having a unique ID for every person in your nation, so that wherever they go, that information can be put under a unique reference. And then you don't have the problem, as we've got in England from a legacy issue, where you may have been to 50 facilities in your life and you have a different reference number at each one. And when you try and bring that together, is this that John Smith or that John Smith or a different John Smith? It's very difficult when people change their name,
their address,
everything. So that's number one, start with that, which is often what they don't want to hear. And number two, agree a clinical vocabulary that you all sign up to, and it's not arbitrary. It's because that way you can really then start to reap the benefits of the data that you will create to help patients, to help reduce costs, to be able to segment patients on the basis of risk, so that you can put scarce clinical human resources in the area they're most likely to help to minimise acute complications, for example, therefore reducing the cost to the healthcare provider. But more importantly, from my perspective, it means that patients are less likely to suffer with a life-changing acute complications. In diabetes, it might be an amputation, stroke, cardiovascular disease. So we move away from a system that's purely a treatment-based system to one that's a more preventative as well as a treatment-based system. And we use that technology to enable that.
Which is what we should aim for, at least.
And we can do it. And it's why we haven't done it. For example, if you look, probably the genesis of the electronic medical record was a paper written by Dr. Larry Weed, published in the New England Journal of Medicine in March 1968. It was entitled Medical Records That Guide and Teach. A great man of great wisdom, and he explained to us in that paper that we needed to standardise on vocabulary so that we could share the data and it would be understood. We'd preserve meaning across them. 50 years on, over half a century on.
And we're still
Sorry,
struggling.
am I going up?
No.
No, half a century. No nation in the world has achieved it.
Yeah.
And I sometimes, you know, although there's been huge expenditure and lots of good people working in the domain, and I think we can achieve so much if we go down that road. And I'm beginning to feel that it may be Asia that if we don't get our act together, Asia will show us the way. And one other thing, if I may. Healthcare is, certainly in the UK, started in small zones. Someone would build a hospital or a health facility in the 1800s, and it grew up into becoming a national system. But we're moving now away from healthcare just becoming national to healthcare becoming international, without walls or boundaries. And therefore, I think healthcare of the future, we start to see it with Amazon, we start to see it with �၀𝐻𝐼, will become a global deliverable.
Yeah.
And therefore, I think we need to start looking at it in that sense. And that means huge opportunities for the companies involved. But more importantly, it means that those billions of people who've never had healthcare before
We'll now have it.
will now have it. And what in life could you do that was of more value?
Yeah, no, I agree.
Sorry.
I think even some of our speakers earlier today, the same thing, basically, you know, there's more noble cause, I guess, than healthcare. And with that, thanks a lot for this. Yeah. No, I think the viewers at home will definitely love your words of wisdom there. Your experience certainly shows. And we look forward to seeing you on stage in the coming days as well to discuss telemedicine and, you know, the way forward with that. Thanks for having us. Sorry, thanks for watching us, and we'll see you later on.
Thank you very much for the invite. I feel really honoured to be here.